Hi, my name is Deborah Friedman, and I am a neuro-ophthalmologist and a headache specialist in Dallas, Texas, practicing at Key-Whitman Eye Center. And I also have an adjunct faculty appointment at Thomas Jefferson University in Philadelphia. I've been interested in disorders of intracranial pressure for most of my career. So I'm really happy to be here to discuss this article with you with my co-discussant, Dr. Stacy Smith.
Hello. Yes, I am Stacy Smith. I am also trained in headache medicine and neuro-ophthalmology. I actually had the pleasure of doing my headache fellowship with Deb Friedman. I am currently practicing in the Houston area with Houston Methodist. I am an assistant professor with the Institute of Academic Medicine, as well as assistant professor with Weill Cornell Medicine. With my background in headache and neuro-ophthalmology, idiopathic intracranial hypertension is a big part of my practice.
Okay, well, Stacy, why don't you kind of start us off with a little introduction about what we're going to do today and kind of where the landscape currently is.
Sure. So I wanted to start with a little background about idiopathic intracranial hypertension. Basically, how did we get to this point? So in the old days, it was called pseudotumor cerebri. That's really not a precise term. So the terminology is idiopathic intracranial hypertension, as it is a primary syndrome of elevated intracranial pressure. Without an underlying etiology. This is as opposed to secondary causes such as venous sinus thrombosis, AV fistula, perhaps sleep apnea, or medication-induced forms. So this is in regards to our, commonly seen disorder where patients are young, overweight females. And so we're typically seeing these patients in their childbearing years as far as what we think about with young. It can happen in younger and older ages, but that's the typical demographic. Our diagnostic criteria has also evolved over time as we've gained a little bit better understanding of who our patients are. 1985 came out with the modified Dandy criteria that were used for many years, but we've since revised that criteria to be a bit more precise. And so Friedman and Jacobson issued a revised criteria in 2002, 2003. And then the current guidelines we're using are actually from 2013 with Dr. Friedman, her associates, defined the diagnosis criteria according to the intracranial pressure, which should be 25 centimeters of water or greater, as well as multiple different signs and symptoms that we're looking for. I won't delve too much into that since it's all readily available, but just getting a sense of where we are with our diagnostics these days. The diagnostic criteria are important because throughout the last few decades, we've been doing several different clinical trials looking at idiopathic intracranial hypertension. Early trials really focused on weight loss. So this is occurring in overweight women, as well as patients who had recently gained weight, led us to look at how does weight loss work as an intervention. In 1998, we had two different studies come out. Dr. Cooper-Smith and Dr. Johnson both had papers looking at how much weight loss was needed to achieve actually the improvement in vision and particularly resolution of papilledema. So it was found that 3 to 6% body weight loss led to resolution of papilledema. So these outcomes were not looking at intracranial pressure per se with a lumbar puncture, it was actually looking at a clinical outcome. Throughout the next 20 plus years, there have been additional studies looking at weight loss showing that really 3 to 15% weight loss helps with resolution of papilledema. And there are also studies showing that it helped normalize intracranial pressure. There is a low energy diet studied by Sinclair and her colleagues that was published in 2010. And that was showing us that about 15% weight loss led to about 8 centimeter of water reduction in intracranial pressure. So this is kind of the background looking at weight loss through the years. We then in 2014 had our IIHTT results. That was a large randomized clinical trial looking at acetazolamide with weight loss versus weight loss alone. And in patients with idiopathic intracranial hypertension. That study had 165 patients, and in that trial, we had a goal weight loss of 6% at 6 months. And in the trial, we found that acetazolamide with weight loss was superior to weight loss alone. We have had less data looking at surgical interventions. And typically our surgical interventions have been for severe symptoms and impending vision loss. So typically we've seen surgical intervention used in very sick patients and not just a go-to as opposed to medicine. There are some patients that don't tolerate medical intervention, and in that case, we also might consider surgeries. And the surgeries studied thus far have been different shunting procedures, ventricular and lumbar peritoneal shunts. They've also looked at venous stenting, which we don't have large trials, but there's actually quite a bit of data supporting venous stenting in some patients now that have venous sinus stenosis with a high gradient. And then another go-to surgery for many practitioners is a optic nerve sheath fenestration, where the cerebral spinal fluid pressure is directly relieved off the optic nerve sheath. However, this study we're going to be talking about, looking at bariatric surgery, we really don't have prior data showing where bariatric surgery fits for these patients. And so we'll go into more detail now about what the actual surgical background is here with the IIH weight trial.
All right, thank you. So the study that we were asked to review is the one that you see on the screen, but I think it's really important to know where these patients, these data come from. Okay, so the parent study for the paper that we will review is called The Effectiveness of Bariatric Surgery versus Community Weight Loss Management Intervention for the Treatment of IIH. It's referred to by most of us as the IIH weight trial. And this was a randomized clinical trial with the goal of comparing exactly what it says, which works better for the reduction of lumbar puncture opening pressure, bariatric surgery versus community weight loss program. The community weight loss program that they used was Weight Watchers, and this was intended to be a 5-year study. The primary outcome is the difference in intracranial pressure between the surgery arm and the community weight loss arm at 12 months. And then there were some secondary outcomes that they also looked at, including various parameters at 24 months, some visual parameters, and some quality of life measures. So the authors actually report in their more recent paper that is a sub-study of this paper. So let's look what they used for doing their post hoc analysis. In the parent trial, they included women between the ages of 18 and 55. They had a BMI of at least 35, which is what you usually need to get bariatric surgery. And they all had what was considered active disease, meaning that the patients or the participants had papilledema at their baseline evaluation. And they also had a lumbar puncture opening pressure of at least 25 centimeters of CSF for at least 2 months. For this study, they used the 2003 diagnostic criteria plus the results of MRVnography. And they excluded people who had a history of optic nerve sheath fenestration, but there is actually no mention of shunting one way or the other. So it's not clear whether anybody in the study had a shunt. They were randomized 1-to-1, stratified by acetazolamide use. 8 people who ended up in the surgery group were taking acetazolamide at baseline, and 11 in the community weight loss group were taking acetazolamide at baseline. So let's look at the consort diagram. If you start with the 66 people that they randomized, they're evenly divided between the two groups. 33 went to bariatric surgery, 33 were randomized community weight loss. Of the 33 in the bariatric surgery group, 6 did not receive the intervention. Okay, so now we're down to 27. And in the community weight loss program, 2 people did not receive the intervention. They withdrew their consent. Go down another set of boxes. And this is where things start to get a little inconsistent for me. So we know that 27 people received the intervention in the bariatric surgery group, but now we have 29 people in the intention to treat group. And I'm not really sure how that happened. They do state that 2 people crossed over, the 2 that declined the participation, crossed over and they got bariatric surgery on their own, but that is not the intention to treat. So I'm a little confused about that. And then there's 25 in the intention to treat group in the community weight loss group. So by the time 1 year rolls around, we still have 90% of our original cohort, which is good, okay? We know that people always drop out in clinical trials, especially if they're very kind of labor intensive. And then at 24 months, we're down to about 70% of the original cohort. But the primary outcome was at 12 months. Okay, so let's look at what they found. There's a lot of stuff in this slide. I'm just going to talk about what's in the boxes. And if you look over to starting the baseline data, you can see that their mean intracranial pressure was about the same in both groups. They were well matched. And here at 2 weeks after surgery, only the bariatric surgery group had another lumbar puncture. And you can see that their intracranial pressure has already gone down from 34.8 to 26.9, okay, at 2 weeks after surgery. Now, 26.9 is pretty close to 25, which was the cutoff value for being normal, okay? And then if you move over here to 12 months, which is about 6, 7 columns over, you can see that of the 25 in the community weight loss group, their opening pressure has not changed much. It's gone down by a couple of centimeters of CSF. And of the 29 in the bariatric surgery group, their mean is now about 26.4. The other thing that I think is important to look at is how much weight they lost. And this is a little difficult in some ways because the weight wasn't measured all throughout the trial, which we'll talk about later. But the community weight loss group started out at about 118 kilograms. They ended up at 12 months at 116 kilograms. The bariatric surgery, about the same baseline weight, but their weight dropped down to 94 kilograms at the time of the primary outcome. So the other thing I think that's important to know about the both of these groups is that the people in the surgery group, and it's not clear if that's 27 or 29 of them, the mean time from their randomization to the time of surgery was about 4.5 months, which is very typical. There are a lot of things you need to do before you can get bariatric surgery. The surgery was chosen by the surgeon and the patient as to which would be the most appropriate for them. And there were 3 different kinds of bariatric surgery employed. So 12 of people in that of the 29 had a Roux-en-Y bypass. Another 12 had gastric banding, and then 5 had a laparoscopic sleeve gastrectomy. In the community weight loss group, the mean number of sessions attended was 14.3. And I guess I'm not sure what the denominator was. So it's either of 31 people or 25 people. If it's of 31 participants who were in the original intention to treat, of the original assignment, that means that 60% of them, well, actually, they say that 61% went to at least 1 session, okay? So that means 40% never went to a session, which means they never got the intervention. So if you look at the 25 participants, that turns out to be actually 75%, and a quarter never got the intervention. But let's just say that a substantial minority of the people who were assigned to community weight loss never went to Weight Watchers and got the intervention. Okay, so the last thing about the parent trial is the other things they looked at. Remember, in the IIHTT, we looked at vision as our primary outcome, not intracranial pressure. So I kind of divided this as to symptoms on the left side and vision on the right side. And the numbers of people that were still in the study are down there on the right for your reference. But there was no significant difference in the treatment arms at either 12 months or 24 months in any of these parameters. Okay, so no difference in headache disability, monthly headache days, monthly days using analgesics, the headache severity, the presence or absence of pulsatile tinnitus, subjective visual loss, double vision, transient visual obscurations, or headache. And when you look at the visual parameters, again, no difference between the two groups, regardless of the amount of weight lost, right? In their visual acuity, their contrast sensitivity, their parametric mean deviation, which is a visual field metric, or their retinal nerve fiber layer thickness on OCT, which is a measurement of papilledema. Now, granted, these people had mild disease to begin with. They had mild papilledema to begin with. So maybe there just wasn't, a lot of room to show a difference of improvement, or maybe just the numbers were too small in the treatment groups. But when all was said and done, that's what they ended up with.
Okay, so let's delve into the actual paper that we were assigned for today. So this is the association of amount of weight loss after bariatric surgery with intracranial pressure in women with idiopathic intracranial hypertension. So this is derived from that original trial as a post hoc analysis. And so what they found were, of the 66 participants, there were definite decreases in intracranial pressure compared to the body weight. Part of why we went into so much detail about the original trial and how the patients were randomized is because if you read this paper, we actually see different groups were used. They had anywhere from 20 to 23 people in their bariatric surgery group for this analysis. I'm unclear on the exact number because in the text it says 20 patients had received surgery, but in their tables it lists 23. So I was just a little unclear on exactly how many patients we had. That's still not the 27 versus 29 from the original trial. This could vary based on exactly when the data was analyzed during that trial, but I simply don't know. And then in our diet group, we actually had 43 participants, which is much more than you see in the primary trial. And in the diet group, there were 2 different weight interventions being used. Patients were assigned to either Weight Watchers or some were undergoing a bariatric surgery diet. My presumption was perhaps some of these patients in the diet group were actually preparing for bariatric surgery and later underwent surgery, but it does not say. And so I just wasn't sure how these patients matched that original trial, but this is where that data came from. In addition, it is mentioned that 18 of them are on acetazolamide, but again, as far as which 18 at this point, I do not know. I think that's relevant when we look at these patients because acetazolamide does have a small weight loss effect for patients, and that is basically part of the outcome we're assessing here. And so they showed that between these 2 groups, those that underwent diet versus surgery, surgical patients had an 18.3% greater weight loss compared to those that were just undergoing the diet intervention. And if you look at the excess weight above their ideal weight, the surgical patients lost 46.4% more weight than those undergoing the diet intervention. And so really they're showing us here that there's a correlation between decreasing body weight and intracranial pressure reduction at 12 and 24 months. And I really like this figure that's showing on the screen because it shows greater weight loss led to greater intracranial pressure decrease. In the study, the mean weight loss required to get your intracranial pressure to the normal range, less than 25 centimeters of water, was actually a 24% weight loss. And if you remember, I was presenting that our old data, we usually were looking at much smaller amounts of weight loss as our treatment plan for patients. But this study found that it took 24% weight loss to get you back to a normal intracranial pressure. And the authors also tell us that only the bariatric surgery group has sufficient weight loss to decrease the intracranial pressure back to that normal range at 12 months. So looking at figure 1, I like that it's a scatter plot. I think there's a lot of interesting information here. This being a post hoc analysis, I actually am interested in individual patients and what led to their outcomes. So A and B are showing us the correlation between the weight loss and intracranial pressure, and I like that nice linear demonstration. C and D are looking at the actual body weight loss percentage and absolute weight loss compared to the actual amount of intracranial pressure decrease. And they're broken out into categories of weight loss. So again, just a different way of representing that same data. But I like looking at the individual points. The kind of pink purple color are our surgery patients, and the blue dots are our diet patients. And as you can see, there's a big grouping of purple squares showing, greater weight loss and greater reduction in intracranial pressure. But there's a few of those little blue circles mixed in there. So while the authors suggested that bariatric surgery was the only way to achieve significant weight loss and significant reduction in intracranial pressure, we see that a few patients that underwent diet alone were able to reduce their weight and reduce their intracranial pressure. To point out a few of these patients here at 12 months, and then over here we see this other one at 24 months. Similarly, when you get down to C and D and looking at total body weight loss and percentage weight loss, yes, it looks like you needed to lose more weight to achieve a greater intracranial pressure reduction. And the vast majority of patients that underwent bariatric surgery showed more reduction compared to our diet patients. And this red line across here is 25 centimeters of water, the normal range. That's the threshold that they wanted as the outcome. Yes, it was primarily bariatric surgery patients that achieved that outcome. However, there were a handful of patients that either reduced their pressure below 25 or got close to it here with only a small percentage of weight loss, and they were in the diet group. So I'm really interested in what made the difference for those patients. Was it diet alone and they still were able to achieve the primary outcome of reducing intracranial pressure, or possibly could these have been patients that jumped groups? If this was, depending on if they started in the diet group at 12, 24 months later, is it possible some of these later did undergo that bariatric surgery intervention? Since our numbers vary throughout the trial, it just wasn't clear if what could have impacted these diet patients that actually had a pretty significant response in our trial. Okay. And figure 2 is another demonstration of the data, and they looked at patients at baseline, 12 months, and 24 months, and they stratified this out based off diet versus the actual type of surgical intervention. I think it's important to keep in mind that in this study, we had very small numbers of patients. I believe only 4 actually even underwent a band. So again, looking at these charts, you have to keep in mind that each group was very small, and so the data must be taken with a grain of salt there. And I do like that they're showing us that separation over time, how these patients were progressing, because you're going to presume that a bariatric weight loss intervention, patients will continue to lose weight over time. Ideally, in a community weight loss program, we'd also like to see the patients lose weight over time. Obviously, our data showed that didn't happen for all patients, but that would be the goal, and then that's what we're comparing as far as outcomes. And not too surprising that those that had surgical intervention had greater percentage of weight loss. And as we already discussed, the weight loss and intracranial pressure kind of go hand in hand. So they also had a greater reduction in intracranial pressure. What's interesting is when you start looking at headache days, headache severity, change in their headache disability with the HIT score, as well as papilledema as measured by optical coherence tomography. You see that's where the lines start crossing. And so for instance, with reduction in papilledema, the banding actually had less benefit to the patient compared to those in the diet group, which I find interesting. However, otherwise, the data are starting to show us that, perhaps bypass would be superior to a sleeve, which would be superior to a band intervention. I don't think I could say that with certainty, but it follows based off, thinking about how significant that actual surgical intervention is. It is a much more invasive surgery to have a bypass compared to a band. So again, this is just, I think, data that is interesting to look at, but very hard to draw definitive conclusions from. And then a final finding from the study I wanted to mention that I found intriguing was in the surgical group, they check the intracranial pressure at 2 weeks post-op. Obviously, it would be hard to define a spot there as 2 weeks post anything in a diet trial. So I can see why the patients did not have another lumbar puncture in that one arm. But in those that underwent surgery at 2 weeks, they already had a decrease in their intracranial pressure from 34.7 to 26.9. And that's a significant drop at only 2 weeks into their intervention. So I found that intriguing, and it definitely made me wonder things like how much weight loss had occurred at 2 weeks, and were there other factors at play from the surgery that could have impacted these patients? Was there something about the surgery itself, possibly affecting other physiologic aspects of the patient that really could have influenced the response in intracranial pressure and other outcomes? So I think there was a lot to unpack with this trial, and unfortunately, we were lacking in some of the details that would have, I think, clarified what we're looking for as far as interpreting their data. But that being said, there's a lot of interesting data here. Deb, any pros or cons you would like to highlight in addition to what I've kind of alluded to so far?
Well, I'd actually like to just say a few things about what you just presented with the bariatric surgery and particularly headache. So there are studies that have been published in the literature looking at people who have migraine and the effect of bariatric surgery and either the amount of weight loss or the rapidity of weight loss on their migraine. And we know that a huge percentage of people with IIH have a history of migraine. We saw that in the IIH treatment trial, over 40% of the people in the IIH trial that was done in the US had a history of migraine. And we also know that the headaches of IIH very frequently have a phenotype that is the same as migraine. So, it could be that the reason that bariatric surgery, was, or one of the contributing factors was that bariatric surgery works for migraine. For whatever reason. And, I think that one of the things that's kind of still a gray area in the study is regarding the timing of the weight loss. And so I did check into some of this stuff. Many centers where they do bariatric surgery, they require at least a 5 to 10% reduction in weight prior to doing surgery. And this is a little controversial. There are studies that support it and studies that don't. But some studies indicate that there's a greater long-term success in weight loss for after bariatric surgery for people that lose the weight before bariatric surgery. And we do know that some of these patients were on a diet before bariatric surgery. So I assumed that was their plan. So, the lumbar puncture, the one that was used for the primary outcome, that was a year down the road. And maybe it really doesn't take a 24% weight loss to make a difference. Because as you mentioned, and as I showed in the original trial, 2 weeks after bariatric surgery, we're almost there, right? 26 centimeters of CSF. That's pretty close. So, maybe if there had been a lumbar puncture done earlier on, when the people in the trial hadn't lost so much weight a year down the road, that maybe we'd have gotten a different number. So if you actually use the number from 2 weeks, which I know that's not quite 25, and it turns out that it was a 12.6% weight loss to get them to 26. And the average person who has bariatric surgery, they lose a tremendous amount of weight within the first month of the surgery, because they're on this liquid diet and they can only drink a few ounces of stuff at a time. And so the amount of weight loss after bariatric surgery in general is between 5 and 10% of your weight within the first month. Mm-hmm. So it's possible that it really doesn't take that much weight loss, and it really doesn't take that long of a time after bariatric surgery to bring your ICP down to normal. Yeah. But I think one of the strengths of the study is certainly that they did this study, okay? Because we didn't have any data before this, and this is not an easy study to do, right? It's not blinded, if you will. We don't like that term, but that's the term. As neuro-ophthalmologists, we don't like that term. Wasn't masked. It was open label. It was very intensive, for people to go through. And face it, whether you're having bariatric surgery or whether you're trying to lose weight by diet and exercise, it's a commitment. It's a major commitment by an individual. So I think the fact that they did the trial was probably the greatest strength. And also, to some extent, the fact that they included different types of surgery, although, as you mentioned, the numbers were small and that part was not randomized. Right. So, but, there are other things that kind of bother me a little bit about the study. One certainly is the inconsistency in the numbers and how you get, 43 people randomized to diet when their parent study randomized 33, of whom only 31 actually got the intervention. I mean, why all the numbers are so different.
Yes, I would be the first to admit I am not strong on statistics. So the first thing I look at is just do the numbers make sense in a paper? And these I really could not make heads or tails of. And then comparing to that original trial, there was a lot of variation. I'm sure there's an explanation in there somewhere. But I do find your comment about, looking at that 2-week data as far as weight loss intriguing, because that's more in line with what we've seen in our other trials in looking at vision outcomes, including the resolution of papilledema, more in that 6 to 10% body weight range. So I agree. I think that 2-week data would have been useful to expand on more. I'd even have been interested to know what the intracranial pressure was going into bariatric surgery, right. Because their
base weight before their surgery
was way before the surgery, and they have to commit to diet in most cases, even before they undergo surgery. I happen to rotate on a bariatric service in medical school, and yes, the patients are put on a very strict diet leading up to it, because this is a big lifestyle change for patients. And I think that's a lot of what the interventions come down to, is lifestyle modification. Bariatric surgery is seen as a nice long-term solution for weight loss. But, if you look at patients, the ones that really succeed with that long-term weight loss are the ones that commit to the lifestyle change.
Right.
You don't make a change. It's a patient that are at bariatric surgery can also regain the weight.
Absolutely. And actually, there was a big meta-analysis that was done of Roux-en-Y as well as sleeve gastrectomy, and found that 17.6% of people in the meta-analysis gained at least 10% of their weight back. So it's a long-term commitment. You're right. Is this going to change what you do? What do you tell your patients? Do they have to lose 24% of their weight? I mean, how do you approach this? Should we be sending people to bariatric surgery earlier or later, or does it just depend?
The way I've approached my patients thus far has been, let's talk about diet and weight loss first. I hesitate to send anyone for surgery too soon because it's not risk-free. We didn't delve into all the possible complications with the surgery, but bariatric surgery patients do have certain complications, short and long term after the surgery, that really could have detrimental effects to their quality of life. So I typically would start with diet and exercise first, particularly if someone has mild disease. If they're not losing vision, we have time to work on this. They present with a fulminant case, then we really have to decide, is there time to even try diet and medication?
Yeah.
Or do we need to jump straight to one of our other surgical interventions? And using this data with bariatric surgery, I think it supports that it could be effective for patients that want to do it. Using it as my first intervention for a patient, particularly with such small numbers that we saw in this trial, it's not going to be my first step. However, if a patient talks to me about bariatric surgery, even that first visit, perhaps they were already planning it. I've had patients come to me with a new diagnosis of IIH and papilledema that we're already starting to work towards bariatric surgery. And maybe in that patient, it's the tipping point. They're already thinking about it. They've already spoken with a surgeon. Let's go. This might be that final deciding factor. But I'm not inclined to throw diet and acetazolamide out the window just yet.
Yeah, I agree. When I talk to my patients, I give them the 6% number because usually it's a realistic thing, and I calculate it out. Patient weighs 200 pounds. I'm like, 12 pounds, you just have to lose 12 pounds. And we know that a lot of the initial weight loss, assuming you're not having surgery, is water weight anyway. And it's a very doable thing. And most people can follow through with that. I will frequently refer them to a weight loss management program. When I was at UT Southwestern, we had a great program that was run by Endocrinology that did medical weight loss. And we know that we now have medications that also help people with weight loss that may be useful for IIH. But, unless, again, people are really motivated to have bariatric surgery, it is a long-term strategy, and often it's difficult to get it covered by insurance. You would think that IIH would be widely recognized as an indication for bariatric surgery. Unfortunately, it isn't always. So, it's interesting. I think I still think that the clinical outcomes are more important than the number of the lumbar puncture. I don't do routine lumbar punctures. When I teach about IIH, I tell people and not to, in the words of Kathleen Degree, worship the pressure, right? Is the patient doing well? Are their headaches under better control? Is their papilledema going away? Are their visual fields improving? To me, that is what is important. We know that CSF pressure varies every minute of the day. And so I still think that clinical outcomes are the ones that are worth seeking.
Yeah, I agree. I definitely look more at the clinical outcomes of my patients. I am not going to repeat a lumbar puncture just for the curiosity of finding out what that intracranial pressure is. I am following their optic nerve exam in my clinic, as well as how their headaches are responding, and approaching my interventions to mitigate those signs and symptoms for the patient. I think it's good to have data showing us the correlation with intracranial pressure improving. But since intracranial pressure itself does vary, and it also, in a given patient, we have that 20 to 25 centimeter water gray zone as far as what does that mean for patients. I'm not going to hang my hat on, getting them to a very precise ICP measurement. So I think my ultimate take home from this study is it's great that we're starting to look in this. And I think it's really raised a lot of questions on where maybe future research should go. Looking at the different bariatric surgeries compared to weight loss alone, acetazolamide, and even our new medications for weight loss that, have just become very popular in the last few years, looking at both, clinical outcomes, cost outcomes, and in addition to the intracranial pressure.
Right, and there is a phase 3 clinical trial going on right now, looking at that in IIH. So, I think we've gone on for quite a while here, and it was fun to do this with you, and it was fun to review the paper. And I think, to me, a lot of the take-home messages are in the reviewing of the paper. And a lot of people skip the methods section, especially the statistics part. But it's important to read the methods section.
Yes.
It's important to look at the tables. Because sometimes things just don't add up, and it's not really clear where it all came from.
Right.
But we're learning more and more about IIH all the time, and I think hopefully the best is yet to come. So thank you for the opportunity to do this.
Great, thank you for including me.